Hello, this is Dr. Todd Snyder. I want to thank you for taking time out of your busy schedule to watch this webinar entitled Composite, Placement Using Stratification and Bulk Fill Techniques. So a lot of questions asked nowadays about what the best way is in which to place a posterior composite. And the nice thing is we have a lot of different options available. I'm going to go through many of the different examples that are available today. And to some extent, it's up to each individual technician to figure out which process or technique and materials work best in their hands. So I think whichever technique you're utilizing has to give you consistent results with minimal to no post-operative sensitivity and be something that can be very long-lasting and reliable. So out of the different techniques I'm going to share with you, hopefully you find one that fits best within your needs of your practice based on time, cost, and materials. So with that being said, let's talk about the different types of ways in which we can place composites using either a stratification and or bulk fill technique. So the first thing we need to think of is what are the most common placement problems we find in placing composite restorations? Well, I think all of us will agree that they're very time intensive, require a lot of effort to place these restorations, and unfortunately there are some drawbacks with sensitivity, micro leakage, etc. So the biggest concern being how can we do a composite restoration in the posterior dentition faster, more efficiently? Well, obviously layering works. We've shown plenty of research over the years that layering can work extremely well, but to take the time to place numerous layers in a deep restoration is challenging. To avoid layering problems of voids or sensitivity or porosities, we obviously have other types of materials to avoid having to do as much layering, which makes life a little bit easier. But getting materials to adapt to the tooth structure, both in adhesion and in placement, are both very challenging. So having materials that are runnier, that adapt quite easily with no part on the dentist having to manipulate materials certainly makes life easy. So various types of flowables and or bulk fill flowable materials are certainly gaining a lot of headway for getting good adaptation, maybe a little quicker and easier than traditional techniques. We also worry a lot about polymerization shrinkage. Obviously, with resin-based materials, we are going to find polymerization shrinkage. But there are ways in which we can offset that, utilizing different types of materials that are becoming available, and we're maybe using different types of bonding agents that are available to us today. And so both of these can help offset some of the polymerization shrinkage stresses that occur on the tooth structure. So the volumetric shrinkage that happens to composites when they are polymerized, that also has to be offset. Otherwise, we're going to have some C-factor problems, post-operative sensitivity. We'll have micro gap formation, which can be maybe white lines or brown stains over time, or maybe just sensitivity post-operatively. So we'll talk about ways in which to minimize these problems. Sensitivity is the other big component that we hear of most regularly. There's numerous different ways in which we can place composites, but sensitivity is something that can happen even if we have a flawless technique. So we'll talk about different ways in which we can minimize that to virtually non-existent in our practices. From there, micro leakage is going to happen. We know composites tend to fail simply because of them being resins and their interaction with tooth structure does decrease over time. We know that in 6 to 12 months we can get 30 to 40% decrease in microtensile bond strengths. So we know we're going to have micro leakage over time as our bonds start to fatigue and fail. So there's probably others that we can't cover in this brief webinar, but these are the main problems we still find with composites that we're trying to offset. And so we'll discuss these along the course of this webinar. So an optimal restoration ideally would have characteristics similar to that of the tooth structure. So behaving just like the natural tooth in its strength properties, its elastic behavior, and that how it deforms under pressures, also how it changes thermally. When someone drinks something hot or cold, does it act like tooth structure in its expansion or contraction? From there, we obviously want things to look beautiful. So having something that has aesthetic properties, that fluoresces just like the tooth, has an opalescence like the tooth, and a gloss just like the natural tooth structure is certainly ideal. That's what we want in our composite-based materials. Surface texture, we obviously want it to feel like tooth structure, being smooth and not having kind of a rough texture to our patients. But in gaining that smooth surface that's considered ideal, we also wanted to have great wear properties. We wanted to be able to hold up and withstand occlusal pressures over time. So having good wear properties is very important with our materials. So when we're placing restorative base materials in the posterior dentition, these composites are under all kinds of stresses, whether it be just from placement techniques and shrinkage going on from polymerization, and long-term stresses based on the dentition. And so when we look at little defects like these, we have a protocol in our practices that we all follow. Some of us may use bonding agents and flowables, others may use bonding agents and traditional composites. There are numerous different modalities. In getting into these small areas, flowables can be very advantageous to get in quickly and easily to adapt to these little areas. But as defects start to get larger, oftentimes having to place more than one increment comes into play. So in using more than one increment, we're going to have to utilize various types of materials. So many of us are currently using flowables with traditional composites on top, or using traditional composites in a couple different increments. And with the advent of bulk fill materials, we can now fill in these larger defects more quickly without having to do as much layering by placing various types of dentin replacement materials and or bulk fill materials entirely from the pulpal floor all the way up to the kegel surface margin. But I think if you look at any one of these type of preparation designs, they all may require a subtly different technique and or different materials based on the speed in which we want to place them, based on the longevity we're trying to gain from them, material wear properties that allow them to hold up over time, and also any type of material we want to place in there to help prevent postoperative sensitivity and or pulpal protection. So a lot of different ways in which to fill these. I wouldn't say there's one process that I would use for all of these. I would probably have a couple different techniques based on the size of the defect. I think if you're trying to use 2 million products for all of these teeth as far as just a bonding agent and a composite, you may have more problems. Oftentimes we need more tools in our bag, so to speak, to be able to manage all these different types of techniques that are shown to us every day. So my question to you is, how are you restoring these different preparation designs? Hopefully using different materials based on the depth and the amount of wear potential that's on them, but I think you need to have more than one option. So the next thing to think about is when we're working on these defects, whether they're small or large, we have to think about what type of substrate we're treating. The substrate being maybe in a superficial cavity like we saw where it's limited mostly enamel, maybe a little bit of dentin, we're most likely placing a flowable and or a very thin layer of traditional composite. But we have a lot of great tooth structure to bind to in these areas. We have enamel, which looks like this, which gives us some of the best bond strengths in dentistry. And we know when we're adhering to these, we can have very minimal postoperative sensitivity. We know we can minimize white lines. We know we can have a very long-lasting, good restoration. The problem with the posterior composites is that as we start getting deeper inside the tooth structure, here we are in superficial dentin. We have an entirely different substrate in which to adhere to. And although dentin bonding has gotten dramatically better over the years, it still has some problems, not only with technique, but also with materials and their interaction with the tooth structure. So superficially, we have very good bond strengths to dentin. We have a lot of tooth structure to bind to, and provided that smear layer is addressed properly, we can adhere to these areas very well. As we get deeper inside the tooth structure, you notice the SEM is now showing more open tubules and less actual tooth structure to bind to. Now within those tubules, we're going to start finding more moisture and maybe even more of a smear layer embedded in there. So again, based on technique and materials, our job is getting a little more challenging as we're getting deeper inside the tooth structure. Now moving even further down into the tooth structure, we'll notice now that we're right up against the pulpal areas, showing an entirely different type of dentin that's covering the pulpal tissues. And so you'll notice here, again, a lot of porosity, a lot of less dentin to bind to. And within all these porosities, we have the dentinal fluids and the abdominoblastic processes. We have a lot more discomfort that's potential in placing our materials in these deeper areas. So 3 times more tubule density equals more fluids, more difficulty in bonding, and even a 30% lower bond strength with most bonding systems on the market. And we say lower bond strength just because of the type of dentin we're adhering to, but also think not only is it 30% because of the strength of the material and the tooth structure, but that strength can be decreased based on your technique and how you're handling the bonding agent and how you're applying it to the tooth structure. So just know as you're getting deeper inside the tooth structure, even though we have numerous types of resin adhesives and materials to fill these defects, having decreased bond strengths down here creates a problem that we will never know if we're going to have post-operative sensitivity or not. So we'll talk about some things that maybe we want to place as a first increment over these types of deep areas, and then go back to composites on top of them. So looking at this type of scenario, going from a simplistic, small, shallow filling to very deep fillings, this is why I'm saying you really need to think about what materials we're placing superficially and kind of in the middle dentin as well as in the deep dentin, that your technique should change based on your proximity to pulpal tissues and the type of dentin that you're adhering to. So flowables, let's go back to more of superficial types of defects. Flowables initially were thought to be used for these small, non-load-bearing areas where we have these deep little tiny spots that was very difficult to get traditional composites into. So in going into these smaller areas, having something that just basically lays down easily with very minimal manipulation is highly desirable. Now the problem with traditional flowables is that they didn't have great wear potentials, so if we had them on large occlusal defects, they would obviously wear out over time. So we minimized the amount of flowable usage on large occlusal-bearing areas. We kept it to small areas such as these, and in these types of areas, flowables can work extremely well. But again, quick and easy to utilize, fluoride releasing, good adaptation, radiopaque, and easily polishable, and made for a great filling for tiny defects. So a lot of different flowables that are on the market. Many of these we can use for not only dentin replacements, but also enamel replacements. And again, these are traditional flowables. These types of materials have been utilized for many years in replacing dentin to try and get better adaptation. But the problem with flowables is we do have 3 to 6% shrinkage by volume. So with any of these composites, we're going to get some level of shrinkage. Now, in comparison to traditional composites typically have a little less volumetric shrinkage. So although they're better adapting maybe in the deeper areas, they have more shrinkage, which allows maybe for more stresses and more potential for microleakage. So although they work to get adaptation, they do have some problems that may arise in these deeper areas. So I tend to use flowables more for maybe a little spot where I need to block out, or more for external cervical and or occlusal areas where we have small defects where I need to get a flowable composite in quick and easy. So I tend to use flowables mostly for external enamel type replacements and occasionally for a tiny little spot where I have a little undercut that I need to flow something into. So all of these are doing a great job. These are traditionals. There are some other composites we'll get to in a moment. We start talking about base replacements, dentin type replacements. They are flowables that are meant solely for dentin replacement and not to be used on enamel. So we'll talk about those in a moment. But most traditional flowables, I would say, use them for enamel replacements, and that's probably going to give you the best long-term results. So in examples like these, where we have a lot of wear on the patient's dentition, we have some tiny little defects we want to restore. These are great areas for these modern flowables that have good strength properties to be placed in these areas and know they're going to have good longevity and wear properties on them. So traditional flowables that we had 10, 15 years ago, not great for occlusal areas, but modern ones have great longevity. So in these little tiny defects, as you start to clean these out or move these pathologies down into the tooth, we can get these to run down in these defects easily and restore the tooth with minimal intervention and have very good strength and wear properties. And then because of radiopaque, even in small defects like these, you can still make them out on x-rays. So the one particular product that I would highly recommend looking into, it's one of my favorites, is the Grandio SO Flow. They have their traditional flow as well as a heavy flow. They both have very good compressive strength properties and flexural strengths. So for on occlusal surfaces or class 5s, they have very good strength properties for these areas. But they also have a modulus of elasticity that's very similar to tooth structure, giving it nice ideal properties, mimicking tooth structure. But for many of us, one of the key components being low shrinkage. So anytime we can have low shrinkage, it's certainly going to help us out in the long run as far as the materials holding up better and having less sensitivity, less microleakage. So let's look at these two. The Grandio SO Heavy Flow on the left-hand side is 83% filler by content. The Grandio SO Flow being a little more runny at 81%, slightly less filler content. So based on your handling properties, both have very good strength and properties, but based on how runny you want something, you may like something like the Grandio SO Flow, which is a little runnier. Me personally, I like something a little fuller. I like the Grandio SO Heavy Flow. But what's interesting in looking at this compared to some of the other flowables, these are very heavily filled compared to many of the other flowables we have on the market. And because of that heavier fill content, we have better properties. Now, if you compare to the far right-hand side, we'll see some traditional packable composites. We can see that these particular flowables from Grandio, from Boco, the Grandio SO products, are just as good as many of our traditional composites we place. And so again, these are great replacements for enamel. Now, Vickers hardness, we'll notice that the heavier filled Grandio SO product compared to the Grandio SO Flow has a little bit better Vickers hardness. That's an indentation type of hardness test. And so we'll notice the reason for that being is it has more filler properties. So I also like the fact not only the handling, but also the property, strength properties are a little bit better than the slightly runnier product. But also in comparison to traditional composites and or other flowables on the market, you'll see that both the Grandio products are doing extremely well for their hardness. Now, I'm looking at shrinkage properties. Again, most flowables have about 3 to 6% shrinkage. You'll notice the far right-hand side, universal composites typically have less shrinkage involved. So in using a flowable for a dentin replacement might not be the best indication because of the amount of shrinkage that happens in an already difficult area. But we all think we get great adaptation by putting these in there the way they lay down. But again, the amount of shrinkage may offset the fact that it lays down easily. But that being said, if you want to use traditional flowables in the dentin, the Grandio SO does have very low shrinkage for a flowable, being that it's under 3%, since most flowables have somewhere between about a 3 to 6%. So again, the flowable doing pretty well, but again, I think these are best served for enamel replacements. Now, as far as being similar in mimicking the dentin, we'll see that the dentin modulus elasticity here in orange is a lot higher. The higher we get closer to dentin, the less enamel-like the material becomes. So this material isn't brittle, but it's not quite as flexible as dentin, so I think it's a great enamel replacement. And if you look at some of the other products out there, not quite the same modulus, but maybe some of the universals get close to it. Flexural strengths, again, because of the higher fill properties that it has very good flexural strength, and in comparison to other flowables and or universal composites, you can see it does just as good, if not significantly better, in its flexural strength capabilities. Now, post-curing, we know that all composites change in their strength properties as they become cured, and we'll notice that all of them drop off a little bit, but still maintaining a very high level of flexural strength with something like a flowable, you'll notice here is doing extremely well. Compressive strength properties, well, you can see that the compressive strength of the flowable obviously just as good as enamel and dentin, and that's why I say it's a great product for using in your occlusal defects that we know it's going to withstand pressures over time to have very long-lasting material. So in small defects like these, where I have a lot of enamel still intact, I can certainly place this Grandio SO quickly and easily with one increment of this 2 millimeter defect and have great longevity, even in an interproximal area. So something like this you could put on your traditional ring systems, place your bonding agents, squirt in your flowable, and have very good adaptation and a nice final product. But as things get larger, such as this one, although it does have great strength properties, I mentioned that the shrinkage properties on it aren't maybe as ideal as traditional composites. So maybe something to look at in this case would be moving to our traditional composites. Traditional composites coming in both syringes and or compules. I would tell you for the posterior dentition, I would stay away from syringes. You're going to have more problems with having to place increments, having to cut it off a syringe and trying to pack it into this defect. You're better off with a compule, in which you can take a compule and under pressure, holding the tip of the compule on the pulpal floor, you can actually inject this material under pressure, forcing it down against the pulpal axial line angles, getting great adaptation. So if you start on maybe the left end of the filling and go all the way down to the right end, and turn around and come straight back, kind of a U shape. So again, starting at this end, going down along the pulpal axial line angles, getting great adaptation under pressure, coming back to your marginal ridge, and actually cutting the material using the marginal ridge to cleave the material from your compule, such that you're never pulling the material off the pulpal floor, will give you great adaptation, so you have to do very minimal compression. So I would say it's not even a compression, it's more of just a light agitation to get your cable surface margins to adapt. So you're not trying to compress into this as much as you're just trying to get it to go over and touch the walls. And from there, using like an egg or ball burnisher to start to draw the material out, start to create some shape and anatomy, going back in with various types of carbers to start putting in your secondary anatomy. And, Peter K. Thomas instrument is a great one for laboratory waxing. It's one that I like to use for placing composites. So you can place some really nice anatomy, but unfortunately, most patients are going to not be happy when you place this much anatomy because they're going to tell you the tooth feels rough. So oftentimes a ball burnisher, an egg burnisher can do a great job, but if you want to take it to the next level, you can certainly use these types of devices to place a lot of great anatomy. So in defects like these, patient walks in, it's 2 millimeters or less. You can place 1 increment of composite the same way I just showed you. And because we have great bond strengths to enamel and superficial dentin, we can get something that looks great and it's going to hold up very well. The problem becomes as these get larger. As we have to start placing more increments, it becomes more stressful and time-consuming on us. And so to avoid this, we will oftentimes want to have a replacement that maybe is simpler and easier, hence modern bulk fill materials. So to diminish stresses in the past, we have to put numerous layers. Now we know with layering we have slightly higher bond strengths by doing horizontal layering, and so to give up a little bit of that in doing some of the bulk fill techniques is going to happen simply because of the stresses involved upon curing. So in moving to something that's more of a 4 millimeter bulk fill, we do give up a little bit sometimes. So out of all the different posterior composites we have on the market, there's plenty of them out there. They all do a really nice job of being placed in layers and or enamel replacements. I think as I've shown you, the Vocal Grandio product, I think does a really nice job with its strength properties, and it's one of my favorite go-to products for an enamel replacement. If I have to place more than 1 increment, I still like that particular product, but there's other options available. So the Grandio SO is 89% filled. I already showed you a moment how I like using the compules for the posterior dentition. You notice the compressive strength is just as good as any other composites on the market, maybe even slightly better. You'll notice here in this graph, we can see it's better than many of the different ones on the market, some of which you may be using currently, but we can see its compressive strength properties are as good or better than composites and or dentin and enamel in its replacement properties, which is great. We want something that mimics tooth structure. Volumetric shrinkage is very low. I mentioned earlier that it's lower than a flowable, and that's why it's more desirable to place traditional composites in multiple increments versus placing a flowable. So if you're going to use a flowable, keep it in a very small amount and then place your composites on top. And again, I'm recommending the Grandio SO for its properties I'm showing you now. Modulus of elasticity is very close to approximating dentin, which is great. If you're going to be placing it deeper inside the tooth, it does have properties similar to that of natural tooth structure and its ability to act like tooth. The same in which for its thermal expansion, you'll see its thermal expansion is minimal, very similar to dentin and its characteristics, dentin and enamel, I should say, compared to many other ones that tend to expand and contract a little more so. Then contraction, obviously, we can see very minimal contraction thermally, which is a very great desirable aspect of composites that oftentimes goes overlooked. We think of how much amalgams expand and contract. By comparison, we know that amalgams can crack teeth over time. So with less thermal contraction and expansion, we have a product here that could be very desirable in mimicking natural tooth structure. From there, obviously water uptake. As resins uptake water, they tend to deteriorate. They also pick up stains. But my main concern is as we absorb water, we have a decrease in properties of the material. So in looking at this graph, we'll notice again the Grandio SO has very low water uptake, which for the posterior dentition means a longer lasting product with less deterioration. And if you were to use this in the anterior dentition, obviously it's nice to have less stains. So if I'm going to be using Grandio SO as an enamel replacement or sometimes a 2-layer replacement, this is how I would approach that. So for this interproximal defect being fairly small, I'm going to place 2 increments because it is over 3 millimeters in depth. We'll put on our traditional ring system. In this case, it's that wonderful product by Truident, the V3 ring. And we'll place our bonding agent followed by 2 layers of the Grandio SO, 2 increments or 2 millimeter increments at each placement. And after placing 2 increments, we have a product that, again, mimics dentin very well, but also is very durable, long-lasting for replacement of enamel. We can get great-looking restorations. So would I have placed a traditional flowable in here first? Me personally, no. Even though you get maybe a little advantage of it laying down, you offset it by polymerization shrinkage, volumetric shrinkage. And so I think better to place a composite that have less shrinkage problems and better mimic the tooth structure. But if you want to have that denser replacement that is flowable, again, I would recommend looking at a Grandio SO heavy flow as that first increment, followed by the Grandio SO on top. So to make life easier, though, since we just looked at kind of traditional modalities, to make life easier, instead of doing stratification with traditional composites, let's look at a dentin replacement with a composite cap. So in using a dentin replacement, we're only having 2 increments of composite, hopefully. And so using, again, traditional flowables as this first increment, they have to be layered at 2 millimeters. So flowable resins having 3 to 6% volumetric shrinkage, and a shrinkage stress of 1.6 to 3 megapascals, you're going to have a little more shrinkage with traditional flowables, hence the advent of modern bulk fill flowables, which are going to have a little less polymerization shrinkage stresses and a little less problems in adapting and getting adhesion. Now, in placing your bonding agent, again, if we're getting into deeper pulpal areas, you have to be very good with your technique and have a bonding agent maybe that has a little more filler properties to give us great adhesion, adaptation, and strength down in those deeper areas. But from there, you're going to have to place something on top of these dentin replacements because, again, these flowables are meant solely for dentin replacement. They're not meant to be exposed on the occlusal surfaces because they will have more wear on them than traditional composites and or traditional flowables. So, again, they are just dentin replacements. And since 82% of dentists are using traditional flowables currently as a base and or liner, these bulk fill materials may be desirable as a larger increment of flowable can be placed to recreate the dentin and not have to do as many layers. But again, you'd have to have a second flowable if you're using these types of bulk fill flowables as dentin replacements. You'd have to have a second flowable product in your practice to utilize for enamel replacements. So again, you can't use one product for both areas. You'd have to now stock two different products, so just keep that in mind. Now, the particular one that I think you might take a look at that does quite well is the Extra Base. Again, this particular product by Voco can be placed in 4mm bulk fill and cures in 10 seconds as compared to 20 seconds with most of the other brands out there. So if you're trying to get something in fast that you can get to adapt very quickly and easily and have a rapid cure of 10 seconds, this may be the product you're looking for. And the other nice thing about this is because it looks like natural tooth structure compared to some of the other products on the market that have a lot more transparency or translucency to them, that maybe makes them not desirable to place in aesthetic areas such as facial aspects of the teeth, maybe the mesial box form, because they would have kind of a gray, irregular appearance. Then this may also be very desirable, not only because of its physical properties and its ability to be cured quickly, but because it looks like natural tooth structure. So from there, you have, again, syringes and or these little compules, unidose, both can work very well. CRA had a nice write-up in January of last year, 2012, on the Extra Base, showing that it had some great properties and very minimal stress when placed in dentin for replacement. So you might look at this particular product. Here again showing some graphs of the compressive strengths. You'll notice the compressive strength compared to the Dentsply SureFill SDR and the Venus Bulk Fill. You'll notice the Voco has a little bit higher compressive strengths, which is great for large amounts of composite being placed under very high compressive forces in the posterior dentition, but also have modulus of elasticity very similar to tooth structure. It's not brittle. It deforms well with the same as a natural tooth structure compared to some other flowables that may be a little more brittle. And again, because it has a higher filler property, that gives it some extra strength and potentially also offsets, giving it a better modulus compared to some other ones that are a little more brittle. And again, shrinkage is a big concern, so again, having less shrinkage than traditional composite or flowable composites is desirable. So again, if you're using traditional flowable composites, you're going to have a little more shrinkage volumetrically than you're going to find with these two particular products here, the Extra Base and the SDR, are going to have a little less volumetric shrinkage, which is better for a large bulk replacement, but also less stresses on your bonding agent. So shrinkage stress, you can see here again, is decreased, which is what we're going for in a bulk fill dentin replacement. From there, water absorption and solubility, you'll notice that the Extra Base has very low water absorption and solubility compared to some of the other ones on the market, which is obviously a big concern down in proximal boxes with its proximity to tissues and moisture. If it is exposed, you want to make sure you're not going to have a lot of problems with water absorption. So in looking at this particular example, again, if we're not doing traditional composites, we're going to place a bulk fill dentin replacement. This is a great area for using the Voco Extra Base. And so I'm just checking colors to see what color I want to use prior to doing my restoration, checking the dentition for occlusion. Excuse me. And so in this case, we're going to go in and place this Polydentia SA Quick Mat ring system, which is really nice, and get good adaptation of that ring system, place our bonding agent, followed by our Extra Base flowable as our first increment, and that's a 4mm replacement. And after placing that to get good adaptation, we'll cure that in place, followed by the Grandio SO as my enamel replacement. And so you'll notice here we're placing the different increments in, followed by curing, and we get a great looking final product. So that's another option compared to traditional flowables, which I think if you're using traditional flowables, you might consider doing this approach so that you have better dentin approximation and replacement because of the physical properties that are available. Now, in doing a bulk fill replacement of the entire restoration being filled with one layer of composite, this can be done also. There's a few of these on the market. Again, requires one layer, provided it's 4 millimeters or less, and I think there's one product on the market that can go 5 millimeters, which is the sonic fill. You have the ability to place one bulk of material. We'll talk about, again, being close to pulpal tissues, that maybe it's not desirable, but it can be done. So again, you want to make sure you have a bonding agent that is typically a 2-bottle system that's highly filled to give it great strength properties to offset the stresses that are going to be involved when you're curing this large bulk of composite. So in something like this, if you want to place one increment that's 4 millimeters inside this to place something quick and easy, again, I would recommend a Composite system so you get the best amount of pressure under adaptation when you're extruding the material, but this can be utilized in one bulk fill technique. Now, bulk fills are the fastest growing section of materials in North America because they are very quick and easy to utilize, saving us time, but also they're hopefully reducing some of the polymerization stresses that are involved and shrinkage that's occurring, which they are capable of doing, but there still is some level of stress that we need to be careful and cognizant of. You also need to make sure your curing light works properly to get to 4 or 5 millimeters deep so that you are getting good polymerization conversion of your material. From there, the materials have pretty good physical properties, so having something to replace tooth structure in a large defect like this certainly is nice. So having great aesthetics, wonderful capability of placing a bulk fill material is going to make life very easy in the placement technique. So again, bulk fill, 4 millimeters max for most of them, 10-second cure oftentimes. They're sometimes a little more translucent, so maybe not quite as ideal in aesthetics for many of them, but it's an offset so that the light can get through some of the products. Now, typical shrinkage on these is fairly low at 1.6 to 2.4%, but again, it's a large bulk. So if you're getting 1.6 to 2.4 on traditional composites at 2 millimeter thicknesses, there's obviously a less volumetric shrinkage because it's a smaller amount of material placed. So remember, in a large bulk of 4 or 5 millimeters, that shrinkage can be maybe a little more significant than incremental layering. So here's just an example of some of the many bulk fill materials that are currently on the market. Curry has their sonic fill, Horaeus has their Venus bulk fill, Dentsply has their Quicks, Ivoclar's got their Tetra Evo ceramic bulk fill, Voco, as I've already mentioned, has got the extra fill and their dentin replacement extra base, as well as 3M having their Fill-Tech bulk fill material. So let's take a quick look at this. The Voco product, again, is one that I would suggest looking into. It's, again, only a 4 millimeter increment, as well as, all the others being 4 millimeter, except for sonic fill going 5. Again, at 4 millimeters, that's a pretty deep defect. And if you're thinking about pulpal proximity again, I personally don't like resins that close to the pulpal area because I know I have decreased bond strengths already, and based on polymerization stresses involved, I know there's a good chance that any composite, no matter what brand it is, has the ability to shrink, and in doing so, the stresses of it shrinking may pull your bonding agent off the pulpal floor. So I think bulk fill composites such as these are great, provided you have a great bonding technique and you're not close to pulpal tissues. So this particular product, again, I would say to use the Compules because you can get compression of the material as you're forcing it into the defect. And at 1.7% volumetric shrinkage, it's very low for the Voco product, but being heavily filled at 86% gives us great wear properties under pressure in the posterior dentition. They have a universal shade, which looks great. It's not transparent and giving a gray appearance. So being that it looks like natural tooth structure makes this very desirable if you're placing a large bulk of material. And you don't require any additional instruments or equipment. You can use it in your traditional composite gun, which makes it easy for adaptation and modification in practice. So here's an example of a great time in which to use one of these bulk fill composites in which we're replacing the existing composite in this premolar. We're going to place our traditional ring systems. You place your bonding agent and then fill it in entirely with one increment of composite. So in looking at the defect, 4 millimeters or less, and again, I have pretty good pulpal distance, so I like it for this area because really the deepest area is my proximal boxes. So a bulk increment in the proximal box, again, can be very desirable to have one increment. And using the Compules under pressure gives us good adaptation when done properly. And on the pulpal area, since we're not close to it, we're only a couple millimeters down on the pulpal area. We're not close where I'm not concerned about it as much. Now, had the pulpal floor been as deep as the proximal boxes, I would probably use a different technique as my first increment. Now, if something were deeper than 4 millimeters, I would place something else down first, and then have no problem or hesitation to place this bulk fill material, the Voco extra fill, on top of it. So again, here's what it looks like afterwards. Great looking restoration with one increment. So the drawbacks of any composite, as I've alluded to, is material placement techniques, polymerization, stress, and shrinkage, as well as water absorption. But more importantly, the stresses that go onto the bonding agents that are being polymerized and having their hydrophobic properties, but also being hydrophilic at the same time, have some problems when they're deep inside the tooth structure, down by the pulpal tissues, having decreased bond strengths to the dentin, as well as just decreased bond strengths as our bonding agents decrease with time as far as their physical properties. Now, the concern with C factor is why we're looking at all these different types of bulk fill replacements with low shrinkage stresses. So if you're not familiar with C factor, the definition showing here is the ratio of bonded to unbonded surfaces. So in looking at the chart here, you'll notice we have C factors from 1 to 5. You'll see C factor of 1 having a lowest stress, something like a class 5, all the way down to the C factor of 5 being an occlusal composite, having the highest stresses, and the one just below that, C factor of 4, being a class 2. So knowing that we're doing the bulk of our fillings as a C factor of 5 or 4, we have a lot of stresses involved. Hence, using many of these bulk fill materials, along with a very good bonding agent, to try and decrease these stress properties is very advantageous. But what might be even more advantageous in these deeper areas that have more C factor risks involved is to think about using maybe a different product as your initial increment and then going back with your bulk fill composites on top. This is a great quote talking about adhesive dentistry in these C factor risk areas, that adhesive dentistry could be expressed as a simple relationship between bonds and stress. So if the bonds, whether it's superficial dentin or enamel or deep dentin, if the bonds to these areas can withstand the stress of the restoration, the composite-based material being polymerized. As it's polymerized, it has stresses not only from volumetric shrinkage, but also the polymerization shrinkage. The stresses that go against that bond to tooth structure. Which bond is stronger? Is the strength of the composite that's shrinking? Does it have stronger properties such that it's ripping that bonding agent off of deep dentin? Or is your bonding agent strong enough, let's say in superficial dentin enamel, strong enough to not be pulled off the tooth structure when that composite is being cured and polymerized? That's the big question, and that's where C factor comes in. You may have more risk of C factor superficially because of the strength properties. You get more deflection of tooth structure possibly. Versus deeper inside the tooth, you may have less C factor stress problems because your adhesion may actually be torn from the natural tooth structure. So I'm looking at polymerization stress as a composite. You'll notice on the right-hand side, we have a light-cured composite. You notice there's a lot more stress superficially. And again, the reason for the superficial stress is because we have great bond strengths to superficial enamel and dentin. So because of that fight between the bond strength of the tooth and the bond to our composite, we have more stresses. Versus deeper inside the tooth, where it takes longer for the light to get to it, the conversion's a little bit slower, and we have decreased bond strengths, you'll notice there's a little less stress. Now, looking to the left-hand side, you'll notice a self-cured composite has very minimal stress because as it's hardening, the stress is being eliminated at a slow rate versus a fast curing process where you're getting everything converging more quickly. So a lot less stress as something is curing slower over time. So maybe traditional composites, a ramp cure or a soft cure or a slower cure could be more advantageous than some of these modern, very quick curing processes. But obviously you want to have a strong light to get all the way down to the pulpal areas with your deep composite layering techniques. So with decreased bond strengths, working deeper inside the tooth structure, we have to be very concerned about not only the tooth structure we're working with and our technique as far as the smear layer that's left behind, but also the handpiece oil that comes out of our instruments, the different types of bonding agents and how well we can place them in these deeper areas, and if we can cure them properly deep inside the tooth. From there, it's all the different material properties we're putting on top of them. All of these can have an effect on our overall bond strength. So what I'm getting to is we have some great materials as we just talked about, but the problem being that we're having different types of tooth in which to adhere to. So in deep preparations, we have this type of tooth structure, which is not desirable for resins, or less desirable, I should say. So placing our traditional flowables and bonding agents may not be a good thing to use here. So maybe a conventional glass ionomer or resin-modified glass ionomer that likes adhering to these areas because it likes moisture, it releases fluoride, has high compressive strengths, it's hydrophilic, it's also insoluble, and it's going to minimize microleakage. The nice thing also that we're all worried about is sensitivity. You don't have sensitivity with these. So again, glass ionomer really enjoys being in these areas. I think this should be a first increment. Now, you also get a wonderful side effect of having an acid-base resistant zone. Makes this dentin a lot more hypermineralized and more resistant to microleakage problems, whether it be acid insults or future decay. It's a lot more difficult when it's already had glass ionomer on it because it's hypermineralized and has this acid-base resistant zone. So whenever we're superficial in dentin like this or on enamel, I think composites and resins are great materials. But you have a lot more problems when you're deeper inside the tooth trying to adhere to dentin. And that's why I think maybe having a different product in these deeper areas followed by a bulk fill composite on top of it may be more advantageous when you're in these deeper areas. So again, physical properties of natural tooth, we have good bond strength to superficial dentin and enamel at about 40 to 60 megapascals. These are gold standard areas for bonding. Now, deep inside the tooth, like I just showed you on the SEM, bond strengths are significantly lower at 10 to 30 megapascals. We have a lot more risk of sensitivity and or pulling our bonding agent off the pulpal floors. And this is where we're going to find postoperative sensitivity, microleakage, and recurrent decay. So if we didn't have a problem with bonding agents in these areas, I wouldn't be recommending glass ionomer. But since we have all these problems in these areas and more risks involved, I think in these deeper areas, glass ionomer makes great sense as your first increment, followed by composites on top. And we also get better bond strengths as we move our preparation more superficial by having a first increment in glass ionomer. So for something like this, where we have a deep defect, we're right down next to the pulpal tissues, we're next to the clavicular fluids and tissues interproximally. Although you can place various types of bulk fill flowables here, as I've just shown you, or traditional flowables or traditional composites, I think I pointed out how we have a lot more risks and problems that could be happening here. And we know when this composite fails, it's usually due to marginal leakage and or adaptation or bond failure in the interproximal areas. So again, that first increment being glass ionomer could save us from having these types of problems with a traditional composite put on top. So this type of defect I just showed you could be shown in this little drawing such as this, where maybe that first increment could be glass ionomer. So we have great adhesion of the glass ionomer to the cementum, the dentin, and the deep pulpal tissues. And from there, once you've placed that, you can now place a bulk fill composite on top. Any bulk fill of your choice, but giving us better properties long term and less risk. Maybe even taking a step further and putting the glass ionomer over the pulpal floor. So now we really have no risk of sensitivity, and we get great adhesion with our composites on top of this to superficial enamel and dentin. And to take it even further, since you can place glass ionomer in bulk fill, you can place it maybe as an entire dentin replacement and then go back with your Grandio SO on top as a wonderful enamel replacement. So again, a bulk fill material could be entirely glass ionomer with traditional composite on top. So a lot of different ways to approach this. Again, replacing the existing restoration and decay, we know we can use resins. We've done it for many years, but we know that it's due mostly to intertubular dentin adhesion. We know that deep preparations have less intertubular dentin. We know there's more moisture and more odontoblastic tissues and fluids, which creates problems for sensitivity and long-term failure of our bonding. So using resin-modified glass ionomers gives us something that offers true adhesion to tooth structure no matter where we are, superficial or deep inside. We know they like moist dentin. We have less technique sensitivity. We have that fluoride release, which is great. It also decreases gap formation and cusp deformation, which we don't find with resins. Furthermore, the coefficient of thermal expansion is very similar to dentin, which makes it very desirable in these deep areas. The other wonderful aspect of it is since we can use it on dentin and cementum and or deep areas to base up the tooth structure, we don't get any sensitivity in these areas because it's self-limiting. In an acid-base reaction, it doesn't have the same postoperative sensitivity effects that you'll find with resins. It's virtually impossible to get sensitivity with glass ionomer when it's pre-encapsulated. It's already pre-measured. All you have to do is mix it and squirt it in. So we don't have the same type of problems we find with traditional resins when we're using glass ionomers. So when looking at this glass ionomer sandwich technique here, you notice the top one, the top image, shows the glass ionomer underneath as this white area, and the composite being on top is red. So the dye penetration study showing the composite having micro leakage over time, You'll notice that this die adapting here at the marginal areas where the composite has actually pulled off the preparation design, allowing for space here and microleakage. The microleakage is shown as the large amount of dye there. Again, that can be from polymerization stress, maybe not having a good bonding agent technique, or maybe the bonding agent was torn from the tooth structure because of the stresses involved, or maybe the bonding agent itself isn't heavily filled to get good strength properties, or maybe it's just technique. There's a lot of different problems that can arise. Now, in looking at the dye penetration on this particular one, what I want you to see with the glass ionomer sandwich technique is the glass ionomer does not show the microleakage problem that you find with traditional composite modalities. And we know composites absorb moisture. You'll notice the composite has entirely absorbed all the red dye, the same as the one here. Glass ionomer has not. So if you do have penetration over time and or microleakage from your traditional composites, the nice thing is the glass ionomer acts as a reservoir, kind of an insurance plan sitting under here, that when it does fail, you really only have to take off the superficial composite and maybe a little bit of the glass ionomer if you want, such that you still have a fresh layer of glass ionomer underneath in which to adhere to, and it's still protecting the tooth. You don't have to take all of it out and go down and maybe traumatize the tooth structure or cause a pulpal exposure. Versus if you have composite from top to bottom, you have to take all that composite out all the way down to fresh tooth structure and place materials again, which creates more risk of sensitivity and problems versus having your insurance plan of glass ionomer could be more advantageous to just take off the superficial composite, resurfacing the existing glass ionomer, and not have to do as deep of a preparation design and have a lot less problems and risks. And the patient has more tooth structure for the rest of their life because you didn't have to go all the way back down to natural tooth structure. So again, glass ionomer may be a great way to approach these deeper restorations. And as I mentioned, the glass ionomer has an acid-base resistant zone. You'll notice here the glass ionomer in this area, the natural tooth down here. This is where the tooth structure's cable surface was, this kind of grayish line. You'll notice there's from this gray line to this kind of diffuse area here is this glass ionomer acid-base resistant zone. So material has actually impregnated from the glass ionomer into the tooth, creating this layer. This acid-base resistant zone is hypermineralized dentin that should this glass ionomer, let's say, fail all the way down to where the tooth structure is, this dentin is actually hypermineralized and more resistant to acid attack from bacteria and more resistant to decay than traditional dentin that never had exposure to glass ionomer. So even if you had a catastrophic failure, you still have a stronger, healthier tooth that can resist problems, and you can go back and bind to this with the glass ionomer again. But since glass ionomers typically have a cohesive failure, you typically don't find failure right at your margin. You typically find it within the material itself, which makes it desirable. So in something like this where I have a deeper defect, I'm going to go ahead and place my various types of ring systems. This happens to be the Garrison 3D XTR product, which is a really nice system also. We'll go ahead and place our glass ionomer as our first increment. I do have a small pulpal protection here, which is a Theracal LC by Bisco, but I'm going to go ahead and fill this up entirely, even the pulpal floor and the proximal box, with glass ionomer. This is conventional glass ionomer. This is not resin-modified glass ionomer. Conventional glass ionomers have higher compressive strengths. Resin-modified glass ionomers have lower compressive strengths. So in a very large bulk fill like this, I typically like to use conventionals. If I was going to do just a small, thin layer of glass ionomer, I would use a resin-modified glass ionomer because I can cure it quickly, and since it has resin, your composite will adhere to the existing resin. In the case of conventional glass ionomer such as this, our resin may not have true adhesion to it. It's more of a micromechanical adhesion, but you do get great adhesion to all the superficial enamel and dentin, so you do have good adhesion that I'm not worried about it, because oftentimes I get asked about adhesion of the two materials and is there going to be failure. Well, as I showed you before with the dye penetration studies, you're really not going to see failure of this glass ionomer, and the only place you're really going to find failure over time is should the composite start to fail and leak around superficial margins. So this is a great way to replace these types of defects. From here, we can go ahead and etch the enamel, and by placing the glass ionomer as an entire replacement of dentin, we're only etching enamel. So we're not getting any etchant onto the dentin. We're not worried about decreased bond strengths from having etched dentin for a self-etch bonding agent. So great to have something like this as a first increment, followed by etching of the enamel, and then a self-etch bonding agent placed on here, followed by Grandio SO as my composite enamel replacement. So I think this is a great way to replace very large defects. And to have glass ionomer buttered up against the adjacent tooth can certainly help out with long-term decay on the adjacent tooth, but also having good adaptation and decreased microleakage. So I think this is a great way to go for our deeper restorations. So you have a lot of different modalities in which to restore a tooth, whether it's traditional composite layering or a small layer of flowable followed by incremental layering of composite, such as we can see here on this image. Or you have the ability for a bulk replacement of dentin with modern flowable composite, bulk fill flowable composites, followed by a capping of enamel, which gives you less layering, so it makes it a little faster. And because of the properties we talked about, you can have decreased stresses inside the tooth compared to traditional flowables. So I think this is another great way to approach maybe middle-sized defects that we're having to restore. And so depending on how much time that you're trying to save in placing your restorations, again, it takes longer to do multiple stratification layers compared to a two-step approach. So maybe if time is of the essence, a bulk fill material, such as the Voco Extra Fill, may be a great product for doing a quick replacement of a lot of dentin and enamel. And you have certainly some questions as far as bond strengths when we're getting deeper inside the tooth. So having questionable bond strengths as we get deeper, as I mentioned, might be more advantageous to place that glass ionomer as that first increment. And in using that glass ionomer as our first increment, we offset that problem such that we're not going to have as many risks of pulling the bonding agent off the pulpal floor, which would entail microleakage over time, maybe postoperative sensitivity, and earlier failure of the material. But also in these large defects, if you ever have to go back, having placed glass ionomer as our first increment, when you go back, you don't have to take everything out. You can take out just the superficial composite. Even if that composite is 4 millimeters deep, the remaining glass ionomer underneath, having been maybe just a millimeter or two, you can leave it intact and not have to worry about getting close to the pulpal tissues, which would create maybe the need for a root canal or postoperative sensitivity. So it makes it easier for you long term, but it also is helping the patient out to not have as many problems and to have a great insurance plan in there because we know inevitably composites will fail and need to be replaced at some point in time. So again, a lot of different options here on how to approximate and recreate tooth structure with all the great materials we just spoke of. So knowing that we have some risks involved with any bonding agent and some of the different materials that we place inside a tooth structure, I think I've alluded to many of the problems with traditional materials as well as bonding agents, such that maybe some of the new bulk fill materials could be better ways to go if we want something that has good adaptation and flowability, that the bulk fill flowable material, such as the extra base from Voco, may be a great increment followed by the Grandio SO, which is a wonderful enamel replacement on top. And should we want something that, again, has even less risks and better longevity, going to a glass ionomer followed by maybe a bulk fill flowable and composite on top, or having a glass ionomer as a first increment with a bulk fill composite, such as the Voco Extra Fill bulk fill composite replacement. So I think with all the risks and longevities, you have to ask yourself which technique works best for you and how deep you are inside the tooth. And having all of these different modalities becomes very advantageous for the different size defects we talked about when we started this program. So with that being said, you have a lot of different ways in which to treat teeth, and I hopefully have given you some insight in some of the different materials you have available and how they can be best utilized based on the size of the defect and what we're trying to replace, whether it be enamel, superficial dentin and enamel, or deeper dentin and enamel.